topic today is rural health care, which is a critical issue for virtually every member of this committee and so many others. I've long considered it a special mission to create the same rural payment opportunities that many of our nation's urban counterparts enjoy. Representing a Western state, I understand the challenges our rural hospitals and providers face to deliver high-quality medical care to families in environments with more limited resources. In the Senate, rural health care policy boasts a long history of collaboration and cooperation on both sides of the aisle. Take, for example, back in 2003 when we passed the Medicare Modernization Act, the MMA included a comprehensive health care package tailored specifically with rural communities, hospitals, and providers in mind. The MMA finally put rural providers on a level playing field with their neighbors in larger communities. The law also put into place common sense Medicare payment provisions that help isolated and underserved areas of the country provide access to medical care as close to home as possible. However, while the vast majority of rural health payment policies enacted in the MMA were permanent, some were only temporary. In the years following, these temporary provisions have become known as the Medicare extenders. As many of us know, the problem with extenders is that annual debate over necessary funding often takes priority over developing a more robust strategic plan for the future. Although some partisan and bipartisan health care policies have since altered Medicare payments, many rural and frontier health care providers still face significant obstacles attempting to successfully participate in Medicare's delivery system reforms and bundled payment arrangements. And while these changes continue to emphasize new ways to pay providers, Medicare's existing strategies to preserve access to health care in rural areas still rely on special reimbursement programs that either supplement inpatient hospital payment rates or provide cost-based hospital payments. Now, these special payment structures may work just fine in certain parts of the country, but even with a wide range of special Medicare rural payment programs, some smaller communities are home to hospitals that still find it hard to achieve financial stability. The reasons, as we will learn from the expert witnesses on the panel today, are complex and multifaceted. For example, when compared to their urban counterparts, on average, the 4 million Medicare beneficiaries living in rural areas, rural and frontier areas, are less affluent, suffer from more chronic conditions, and face higher mortality rates. To make matters worse, small rural hospitals continue to be more heavily developed or dependent on Medicare inpatient payments as part of their total revenues. At the same time, we are seeing a steady nationwide shift away from inpatient care to providers offering more outpatient services, it seems to me. Many rural hospitals serve as a central hub of community service and economic development, but some struggle to keep their facilities operating in the black in order to meet local demands for a full range of inpatient, outpatient, and rehabilitation services. Resolving these issues is no easy task. Clearly, for some communities, Medicare's special rural payment structures, I guess I should say, may stifle innovations that could pave the way for more sustainable rural healthcare delivery systems. One consistent theme that we will hear from our witnesses today is the need for flexibility. They're not asking Congress for a one-size-fits-all federal policy. They want the flexibility to design innovative ideas that are tailored to meet the specific needs of the communities they serve. They need the federal government to support data-driven state and local innovations that have the promise to achieve results, increasing access to basic medical care, lowering costs, and improving patient outcomes. But the federal government cannot tackle this challenge alone. While I was pleased to see CMS release its rural health strategy earlier this month, I believe that this administration, led by HHS Secretary Azar, still needs to improve coordination across the agencies within the department to help prioritize new rural payment models, while also reducing regulatory burdens on rural and frontier providers. State and local officials must be aggressive in their efforts to design transformative policies and programs that meet their unique rural health care needs. And the federal government really needs to listen. We should listen to what these folks have to say and how we can, what some of the solutions really are. In my view, states should be the breeding ground to test new ideas. However, it is not sustainable for every small town to have a full-service hospital with every type of specialty provider at its disposal. That is why it is so important for rural communities to work together, share resources, and develop networks. The federal government must continue to recognize the important differences between urban and rural healthcare service delivery and respond with targeted fiscal responsible solutions. By pooling our knowledge, expertise, and financial resources, we can work together to develop targeted payment policies that ensure appropriate access while also protecting Medicare beneficiaries and American taxpayers. Now, I'm looking forward to hearing some of those innovative ideas from our witnesses here today. But before I turn to our ranking member, Senator Wyden, I want to bring one important item to the attention of the committee. The Medicare Payment Advisory Commission, otherwise known as MedPAC, has submitted a statement for the record outlining the Commission's latest recommendation aimed at ensuring access to emergency development services for Medicare beneficiaries living in rural communities. I encourage all members to review MedPAC's statement and ask that it be made part of the official hearing record. With that,